So excited to be here, excited to talk about Medicare Advantage today and present some what research has to say on the subject and get into some actual data and facts and numbers. So to some extent, the data and the details are not even needed to demonstrate that patients prefer, or a lot of patients prefer, MA over traditional Medicare. The proof really is in the pudding. The fact that over half of Medicare beneficiaries are now in MA reflects Medicare beneficiaries' preference for MA. So I'm a health economist, and health economists have this principle called revealed preference, where people's preferences are implied or reflected in their actions. And the fact that so many Medicare beneficiaries are freely going into MA is as strong a signal as any for the value that MA is delivering to them and to the Medicare program as a whole. So I could end the presentation there and let you enjoy this not so sunny day, but I do want to get into some of the research on the specifics for exactly how MA appears to be improving the patient experience, really delivering value to patients compared to traditional Medicare. And before I get started, just a few details about myself. So I'm a health economist by training. I'm on faculty at Harvard Medical School. I'm also an affiliate of AEI and the USC-Schaeffer Center. I use different kinds of data, especially big data, to study key questions in Medicare Advantage, really trying to shed data and shed light on these key issues, looking especially at how MA compares to traditional Medicare along various important dimensions. As part of my work, I collaborate closely with different healthcare organizations, policy organizations, companies, leveraging their resources, leveraging their data to really get at these important policy questions as best as I can. So to start, a brief overview on just what the research says. So the research says pretty convincingly, pretty resoundingly, that MA, first of all, it helps disadvantaged patients. It helps all patients, but it helps disadvantaged patients disproportionately, given that disadvantaged patients are so much more likely to enroll in MA than any other kind of patient. MA also has a particularly large benefit to patients' pocketbooks. I will get into that in greater detail, but in my latest research, I found that a typical beneficiary has 25% lower overall out-of-pocket cost under MA compared to traditional Medicare. And in terms of dollars and cents, that 25% really adds up. It comes out to a big number. The research also says pretty resoundingly that MA delivers meaningful and significant benefits in terms of patient health. So along a pretty broad set of different quality outcomes, MA has been shown to deliver superior outcomes compared to traditional Medicare. And finally, MA provides a lot of choice to patients. So as patients are considering MA, they can choose from a pretty wide variety of different MA plans and ultimately choose the MA plan that's best for them. So when patients are choosing between MA and traditional Medicare, it's not just a binary choice, because even within MA, there's this spectrum of different options that patients have, and that's one additional advantage. So starting first with how MA disproportionately benefits disadvantaged beneficiaries. In some of the latest research I've done in collaboration with the health analytics company, Inovalon, we found that MA beneficiaries have 15% lower income and 25% lower net worth compared to those in traditional Medicare. We also found that MA beneficiaries are twice as likely to be non-white as those in traditional Medicare. And in this particular study, we excluded dual eligibles. So in some ways, these numbers, they're actually understating just how much more disadvantaged Medicare Advantage beneficiaries are. And in a bit, I'll get into why MA might be as attractive to disadvantaged beneficiaries as it is. But in terms of other dimensions along which MA beneficiaries appear to be more disadvantaged. So prior to enrolling in Medicare, future MA enrollees had lower access to care and worse quality outcomes than those going into traditional Medicare. They also appeared to be sicker in terms of their age 64 diagnoses, age 64 utilization than those going into traditional Medicare. And again, this goes against some of the prevailing narrative that MA patients are actually super healthy compared to traditional Medicare, when in fact they're not, based off all of this evidence. Dual eligibles also have a higher rate of enrollment in MA than non-duals. Right now, MA is increasingly becoming the dominant coverage option for dual eligibles. And then moving on to pocketbook issues. So this is where the evidence is especially clear. In a recent set of studies, I used CMS's own data, own projections around beneficiary out-of-pocket costs under different MA plan options and under traditional Medicare. So again, this is CMS's own data, CMS's own projections that previously were featured in Medicare Plan Finder, but for inexplicable reasons are no longer featured in Plan Finder. In any case, CMS's own data shows that total out-of-pocket costs under MA were about 25% lower for a typical beneficiary compared to what they would have been under traditional Medicare. So this is including the full suite of out-of-pocket costs, premiums, deductibles, co-insurance, co-pays, and in terms of raw dollars, this adds up to about $140 per member per month in savings. And this is an average, so this number is going to be even higher for certain types of patients or certain types of MA plans. So for example, for MAHMOs, it's going to be higher. For more sick patients, it's going to be higher. MA also delivers supplementary benefits to beneficiaries, such as vision, dental, transportation, and other features that folks in this audience are certainly well familiar with. And based off CMS's own numbers, this adds up to about $21 per member per month in additional value for beneficiaries. More than 90% of MA beneficiaries are in plans that provide drug coverage or additional integrated Part D benefits. So looking at the drug benefits that MA plans are offering, in recent research, I found that MA plans cover more drugs than standalone Part D plans. And this is true across a pretty broad set of drug classes. And then looking at out-of-pocket costs for drugs, again, in recent research, we find that MA plans have lower out-of-pocket costs for drugs than standalone Part D plans, about 25% lower. And again, this isn't using my own data or my own projections. This is using CMS's own data. Now, moving forward to quality and how MA might impact quality of care compared to traditional Medicare. So the evidence on this point is also pretty clear. In recent research using pretty sophisticated quasi-experimental designs, I found substantially lower inpatient admissions under MA compared to traditional Medicare, especially concentrated among avoidable admissions, readmissions, ED visits. So a lot fewer of the kinds of things that patients don't want. So a lot less undesirable outcomes under MA compared to traditional Medicare. Research, not my own research, but other research out there, has also found improved quality metrics under MA, including across a broad suite of standard HEDIS indicators. My research has also found increased access to care under MA, including to outpatient care and preventative care. Just conceptually, it's well known that MA has much greater care management, care intervention than traditional Medicare does. Traditional Medicare is basically a benefit that's still stuck in 1965. That's really an outlier in terms of its benefit design compared not just to MA, but pretty much any other common insurance out there, like compared to the standard employer-based coverage that most folks in this room currently have. And so what that means is, unlike traditional Medicare, MA actually has designated primary care physicians for beneficiaries. A lot of MA plans will feature care coordination for beneficiaries. Risk-based payment models to physicians are also highly prevalent under MA. So I'm actually doing some research collaborations with Susan Denser at APG and with a number of different APG groups. And I know that Susan will be speaking later today. But we found in this research all the different kinds of benefits that these at-risk payment arrangements or care management arrangements ultimately deliver to patients. And now, anyone, it seems like there's a million statistics out there. So it seems like maybe some of this is just being cherry-picked, where, people can present good statistics, people can present bad statistics. But zooming out, I can say that none of these numbers are cherry-picked, because looking at broad reviews of the overall research, the vast majority of research does find these kinds of quality improvements under MA compared to TM. So, for example, there was a review recently published of the MA literature in health affairs, and it found that 6 out of 7 leading studies found reduced hospitalizations under MA, and 5 out of 6 of the latest studies found reduced ED visits under MA. And now, moving on to how MA delivers choice and options for patients. So the typical patient can choose from over 40 MA plans, or choose between over 40 MA plans offered in their county. And the amount of choice that beneficiaries have has actually been increasing over time. It's more than double the choice that beneficiaries had 5 years ago, and it's much greater than what beneficiaries, say, had 20 years ago before the Medicare Modernization Act. So before the Medicare Modernization Act, beneficiaries could effectively only choose between MA HMO plans, and MA plans had much less flexibility in terms of the offering that they could deliver to patients. Now, there's a lot of different plan types out there. There's HMOs, there's PPOs, and beneficiaries can trade off between managed care restrictions and cost savings. So if a beneficiary wants more flexibility, they can get that additional flexibility in MA simply by choosing a PPO plan over an HMO plan. Now, in my research, I found that socioeconomically disadvantaged beneficiaries end up going into HMO plans at higher rates. And, that's to be expected given that socioeconomically disadvantaged beneficiaries are going to place more value on the financial dimension and the financial savings that they can get from HMOs. Meanwhile, on the PPO side, there's massive flexibility that that beneficiaries can get. PPOs are going to allow out-of-network doctor visits, and beneficiaries, for the most part, will be able to go to any doctor who takes traditional Medicare. And so this is the fact that beneficiaries have these options in MA or through MA, that beneficiaries can get this kind of flexibility even under MA. This is something that appears to get lost in the narrative. And on the drug benefit side, as I mentioned earlier, over 90% of MA beneficiaries are enrolled in MA plans that have integrated drug benefits. And there's a lot of different drug coverage options that MA beneficiaries can choose between. So different MA plans are going to cover different drugs, are going to have prior authorization restrictions for different drugs. And MA beneficiaries, they can choose between these plans and ultimately zero in on the plan that covers their basket of drugs the best. And so I just delivered some statistics on the benefits that patients get across these different dimensions. But then that begs the question of just how much does MA help patients? And the answer is a lot. So, for example, the out-of-pocket cost savings that beneficiaries get under MA, they add up to some pretty big numbers. And now, $150 a month might not necessarily sound like a lot to folks in this room, but it ends up being a lot for the typical Medicare beneficiary. So out-of-pocket costs, for example, under traditional Medicare, they add up to about 30% of the average Social Security benefit. So MA reducing out-of-pocket costs by 25% is equivalent to MA delivering a 7% raise in beneficiaries' incomes. So that's pretty meaningful. And on the quality health outcome side, the degree of improvement under MA is also very substantial. So 70% reduction in readmissions under MA compared to traditional Medicare, 22% reduction in ED visits, 20% reduction in high-risk drug usage. And I could go on and on listing these different statistics, but we only have 45 minutes today. So, but putting it all together, so one thing I wanted to bring up was the recent MedPAC analyses that claim that MA costs the government more than traditional Medicare. But one piece of context that seems to be missing in MedPAC's analysis and MedPAC's framing, among other issues with the analysis, is that it makes the comparison out to be apples to apples, or does a comparison on apples to apples basis, when it's not. MA and traditional Medicare provide fundamentally different benefits, and MA provides fundamentally more generous coverage to patients. And so the right way to do this comparison on the apples to apples basis is to compare the cost of the standard MA benefit to the cost of traditional Medicare, not accounting for supplemental benefits that MA plans deliver. And that reduces the cost of MA by 15 percentage points, and ultimately doing some other math, suggests that MA is actually cheaper than traditional Medicare. So just making the comparison apples to apples totally changes the MedPAC conclusion, without correcting any of the other potential errors in the MedPAC analysis. So all this begs the question of why these facts are not more widely known or covered in the media or in the policy community. And there's a few potential explanations. So one is complexity. Some of these topics, like out-of-pocket costs, they can be hard to understand, hard to quantify, especially given that, for example, out-of-pocket cost of insurance to beneficiaries, there's a lot of different parts to it. There's deductibles, there's co-insurance, there's co-pays, and it all can add up in seemingly mysterious ways. And so even beneficiaries themselves, at best, they might have a gut feel around, how much MA is costing them compared to how much traditional Medicare would cost them, and how much in cost savings they're getting from MA. They may realize they're getting cost savings. They might just not realize how much in cost savings they're getting. Again, because out-of-pocket costs, there's a lot of different moving parts to them, and it's just hard to understand. And then what compounds the problem is that CMS does not provide a lot of information or context to beneficiaries. So as I mentioned before, CMS included out-of-pocket cost estimates from its own model in Medicare Plan Finder, showing some of the potential cost savings that MA plans would deliver to beneficiaries, and showing it to beneficiaries as they're choosing between MA and traditional Medicare. Now, CMS no longer provides this context to beneficiaries starting in 2021. And that context, that was, even then, it was just limited to Medicare Plan Finder. That a lot of that information, even from CMS's own models, isn't really making it into the wider policy discussion or policy conversation. And to that point, because a lot of the data is not out there, or out there on a very limited basis, a lot of the MA stakeholders might be similarly uninformed, or only informed to a limited extent about the value that MA is bringing. So another issue, at least from my viewpoint, is that there's just a lack of context and a lack of realization about how important some of these pocketbook issues really are to MA and to Medicare beneficiaries. So to folks in this room, or to various key stakeholders, $150 per month might not seem like a lot, but to a typical Medicare beneficiary, it does mean a lot, because as I alluded to, traditional Medicare out-of-pocket costs, or out-of-pocket costs on average under traditional Medicare, add up to about 30% of the typical Social Security monthly check. And then there's, I think, a third key area of misunderstanding that's driving some of this, and that's that people are misunderstanding Medigap and what Medigap actually does or could do for beneficiaries. So a lot of the prevailing assumption seems to be that even if MA might deliver out-of-pocket cost savings compared to traditional Medicare, beneficiaries can get the same thing just by going to traditional Medicare and signing up for Medigap on top. But what they're missing is that Medigap itself actually costs beneficiaries money, and in a lot of cases costs beneficiaries a lot of money. The key factor here is that Medigap is not subsidized by the federal government. So the premiums that beneficiaries pay for Medigap are going to, on average, fully offset any savings in terms of deductibles or co-insurance that they get from Medigap. So Medigap is not an alternative way for beneficiaries to save costs, because Medigap on average is not going to save beneficiaries costs. It's just going to reduce their risk. And so again, that appears to be a big reason for some of these misunderstandings. And so if you have any questions or comments about this slide deck or any of the research that I've done or referenced, definitely don't hesitate to contact me at this email address. And in the meantime, I'd love to open up the floor to questions that folks might have.
Thanks, Boris. I always love hearing you speak and appreciate it. So Jeff Lowenkron, Villages Health. One of the things that basically MedPAC and CMS have concluded is that what's being spent on MA out of the CMS budget is higher than it should be relative to fee-for-service. And that increase is now driving the Part B part of what comes out of people's Social Security checks to fund it. So they're viewing it almost like a tax increase. And it would be nice if you would do a study that would show that because of who selects MA, it's really a wealth redistribution program. So the wealthier folks are paying more without a question out of their Part B for the Part B benefit. But they're selecting things that are not MA. The poorer people who are selecting MA get benefits back, including flex spending cards, other benefits that have true dollar numbers for them. So when they do the calculation, as you said, their out-of-pocket expenses and their true dollars that stay in their wallet is higher. So if you can figure out what the true wealth distribution for that process is, I think you have all the data available to do it. That would be really, really helpful in driving that dialogue.
Yeah, absolutely. And that's a great point that, ultimately, MA is a wealth distribution vehicle implicitly, even if not explicitly. It's delivering, disproportionate value to disadvantaged beneficiaries. Because a lot of the folks who remain in traditional Medicare, they're either wealthier or they have sources of supplemental coverage from their employer. Relatively few folks in traditional Medicare are ones who are going and paying for Medigap on their own. So effectively, most folks who have no other options for subsidized supplemental coverage, either via Medigap or either via Medicaid or some kind of retiree benefits, they're going into MA because that's really the best and only option they have available.
Yeah, I was thinking about, your focus on the supplemental benefits, et cetera, that MA plans offer. If the Congress, let's say, decided to take some of those benefits and try to apply them to fee-for-service, I mean, you probably don't have an exact number here, but how would you think about sort of like the cost to the taxpayer of trying to add not just like vision, dental, and hearing, but some of these other benefits like transportation and meals that some plans offer to fee-for-service to make them sort of more equalized? Like, what would that end up costing, the Treasury Department in trying to finance all that?
Well, it would certainly be considerable, and it would be certainly well above, 10% of what the government currently spends on traditional Medicare. So you'd be talking about double-digit increases in traditional Medicare spending just to get traditional Medicare even close to where MA is in terms of coverage generosity. And as you alluded to, Don, MA does deliver some of these supplemental benefits like transportation, gym memberships, but in terms of dollars, a lot of the biggest ticket items are actually coming from premium reductions, deductible reductions, co-insurance, maybe the kinds of things that aren't getting people's attention as much, but in terms of dollars and cents really add up to a lot. Okay, well, if there are no other questions, I'm happy to wrap up. And again, please don't hesitate to contact me in regards to the research out there or any of these studies that I referenced.